Hello, everyone. This is Shad Reis from Detroit Medical Center. ACC 2022 just wrapped up, and there was a lot of trial presented. One of the highlights related to interventional cardiology is the FLAVOUR trial. With me is Dr. Tanveer Rab. He is a professor of medicine, interventional cardiology at Emory University, and he will go over a summary of the trial that's related to interventional cardiology. Dr. Rab, thanks for being with us.
Thank you for the invitation. Thank you for SCAI asking me to review this. So this is a very important study in my mind because it uses two common technologies in the cath lab, which is a pressure wire as well as intravascular ultrasound. So it's not uncommon to see intermediate lesions when patients come to you with a chest pain syndrome or abnormal myocardial perfusion scan imaging, and you decide what you want to do next. Should you tackle this lesion, leave it alone, go on angiographic criteria, manage it medically or not? So Dr. Koo and colleagues from Seoul, Korea, just today presented a very nice presentation on comparison of fractional flow reserve and guided intravascular ultrasound guided percutaneous coronary intervention for intermediate coronary lesions. And basically, they're randomized. They randomized 1,682 stable patients with coronary disease in the 1-to-1 ratio between fractional flow reserve guided PCI versus intravascular ultrasound guided PCI. A small group of patients left to medical therapy, and the criteria they used, and there's some question on that today, was for the ultrasound criteria was they took a minimum luminal area less than 3 millimeters square, equal to less than 3 millimeters square, or 3 millimeters square, or MLL equal to less than 4 millimeters square, and plaque burden greater than 70%. When asked why this was the case, I think Dr. Koo's answer was that this was because of the stability of the patients in this group. Now, for FFR, they used a criteria of less than or equal to 0.80, and they were able to show that in the pressure wire group or the FFR group, there were less stents used, 44.5% in the FFR group and 65.3% in the intravascular ultrasound group. And they followed these patients for 2 years. Majority of these patients were males, and with 65% of them being diabetic. And the 65 years of age, with about 1/3 or 32.9% of them being diabetic. So very well matched. There were a few women, however, in the study. So what they showed over a period of 2 years, there was no significant difference in endpoints of death, myocardial infarction, or repeat revascularization in either group. The patients with intermediate coronary lesions, okay, were able to get fewer stents if they had pressure wire-guided evaluation, and therefore less resources, and there was less need for DAPT, okay? Now, this was a non-inferiority trial, but in the contemporary cath lab practice, you know, it's very easy probably to use a pressure wire, and obviously ultrasound requires more measurements and expertise into interpretation. So for the interventional cardiologist, for the average interventional cardiologist, really is a good tool to utilize in the cath lab. Now, having said that, what is it? There's no data for IFR or RFR or QFR to compare in this trial. So it's very important that what people are using now, which is the either IFR, RFR, or QFR technology, get some idea or clarity about these new technologies, and that can only be answered by future trials. So this is an interesting study that shows the value of pressure wire intermediate lesions. It's non-inferior to IVUS, and certainly less stents were used.
Thank you, Dr. Rab, for the great summary about the FLAVOUR trial. Please watch these summaries and others on SCAI-TV YouTube channel. I am Dr. Shad Reis and Dr. Tanveer Rab from the SCAI Communication Council, and this is a wrap-up from ACC 22. Thank you, Dr. Rab, for your time.
Thank you very much. Thank you for the invite.